Welcome all to this evening session of the CME that we're going to have today. And the topic for today is pulmonary embolism. Very common and still a less understood topic where compared to the myocardial infarction, compared to the cerebrovascular stroke, information is not that very much available for pulmonary embolism in terms of your epidemiology, the diagnosis and the treatment. We still have certain concerns. So I think with that background, it's an important aspect for all of us to be understanding and knowing in a day-to-day clinical practice. So we have Dr. S. Saha, who is an Associate Consultant Medical ICU Apollo Kolkata. And he's an MBBS, MD, DNB with MRCP and DM Critical Care Medicine, and also at DRNB. That's very nice to get to know the credentials. So with these few words, I would like to invite you, Dr. Saha, to take us forward with the details on pulmonary embolism.
Thank you, sir. So today's topic for discussion is pulmonary embolism. So pulmonary embolism is one of the things that we encounter in the ICU, maybe not very frequently, but we need to have a very open mind because we need to suspect that the patient may be suffering from it. Because the clinical features that we shall discuss that the patients usually have, that can be masqueraded as any of the typical findings of any patient of sepsis or other or pneumonia. So pulmonary embolism is difficult to diagnose, but early diagnosis and proper management, as we shall see, can have much better outcomes. So these are the headings that we shall study the topic today. So firstly, pulmonary embolism, the rate of pulmonary embolism varies widely. Per lakh population, in anywhere between around 40 to 115. This is because of the problems. One of the reasons for this great variation is the difference in diagnosing the cases of pulmonary embolism. The overall incidence increases exponentially with age, but as we have noted here, that the trend of deaths per lakh population is decreasing. So despite this is possible because of the advances in the advances in the diagnostic modalities available, and the more wide use and availability of these modalities, that we are able to diagnose the pulmonary embolism and early treatment initiation, resulting in fewer deaths. So, in the case of pulmonary embolism or any of the embolisms, fat embolisms or like these things, the mortality rate is pretty high. But in a case of pulmonary embolism, whether it is a small pulmonary embolism or a massive embolism, whether the patient is hemodynamically stable or unstable presentation, and whether the patient has present cardiogenic shock or needed resuscitation or CPR, so the mortality rate greatly varies depending upon these things. In India, the incidence of venous thromboembolism is around 17 per 10,000 admissions, with malignancy being the most common factor, followed by surgery. As we know, the orthopedic patients, the rate is around 20%, and we usually, because the orthopedic patients, in a case of femur fracture, tibia fracture, the weeks of or the months of the bed rest or immobilization is much more. So the incidence of pulmonary embolism is much more in these patients. The acquired risk factors we shall discuss in the next few slides. I mean, the genetic risk factors we often get like just a few weeks back in our center in Apollo, we got a patient who was suffering from APLA. The patient did not have pulmonary embolism, but APLA itself is a factor 5 mutation or protein C protein deficiency is a high risk factor of pulmonary embolism. A young male around 32 years old presented with severe shortness of breath and hemoptysis, and we did and the patient was I think a young diabetic and no other comorbidities, no malignancy definitely, and no surgery. And we found that there is a saddle embolus obstructing the main pulmonary artery, along with multiple small emboli in both left and right pulmonary artery. So we did the workup and we found that the patient is suffering from both protein C and protein S deficiency. So although factor 5 mutation is the most common among the genetic risk factors, others are also prevalent. And among the acquired risk factors, there is subdivision. The strong risk factors, as highlighted here, and are fractures of the lower limbs, hospitalizations, major trauma, previous history of embolisms or spinal cord injury. Whereas The moderate risk factors, you can read the oral contraceptive therapy, postpartum period, and malignancy, especially pancreatic malignancy, hematologic malignancy, these things. But the weak risk factors like bed rest for around 3 days, only diabetes mellitus, arterial hypertension, these are also risk factors. So usually what happens is that usually the patient is a malignancy patient who has maybe a previous VTE or a hip or knee replacement, and diabetes mellitus or arterial hypertension is also present. So combination of the weak risk factors along with the strong risk factors or a couple of moderate risk factors makes the patient more prevalent to the thromboembolism rather than the weak risk factors alone. Because only obesity, only pregnancy, only diabetes, only hypertension are present in a lot of patients. They do not get pulmonary embolism, right? But a malignant patient with diabetes or hypertension is much more expected to get a pulmonary embolism rather than a patient without other risk factors and only weak risk factors. So, like, what happens when there is a pulmonary embolism? As you know, in a pulmonary embolism, the pulmonary vessel that is obstructed by a clot, by an embolus. So the blood cannot move from the RV to the along the heart. So there is an increase in the RV afterload, and because in the RV afterload increases, there is a stagnation in the blood and increase in RV volume, and the RV and the LV are side by side, right? So the septum that shifts towards that, usually the LV pressure and volume are much more. So the septum is always bulging towards the right. But when the RV volume increases, the bulge of the septum goes towards the left. And so LV distensibility also decreases. That decreases the LV preload, and ultimately resulting in decreased cardiac output, decreased MAP, and all the features that happen, that the cardiovascular collapse, that, or at least the cardiovascular compromise that happens with the pulmonary embolism happens. So it's a combination of both the decrease in RV output because of disease itself and a decrease in LV output because of the decrease in LV preload because of the bulging of the septum towards the left ventricle. And this is called a spiral of death. The increased RV afterload, the RV dilatation, and with the RV ischemia, hypoxic injury, decrease in LV preload, coronary perfusion decreases, and ultimately decrease in oxygen delivery, and ultimately obstructive shock. So this was about the cardiovascular compromise. What happens when there is a respiratory compromise? So cardiovascular compromise we have discussed. What happens when there is a respiratory compromise, or how the respiratory compromise occurs? The main villain is this VQ mismatch, because the part of the vessel which has been obstructed by the clot, there is no perfusion, but the ventilation is there. So obviously it is ventilation perfusion mismatch. And there is also decrease in cardiac output, as we discussed, resulting in decreased oxygenation, shunting, and most importantly, usually we think that there is an infarct, right? There is an infarct, and that is the reason why there is this whole of CV compromise and respiratory compromise. Rather than that, in fact, if we see that around 10% of cases, there is a small thrombi which lodge distally into the segmental or subsegmental vessels, and the overall effect is pretty mild. So it is mostly because of this VQ mismatch, because of the shunting, and because of low cardiac output that the respiratory compromise occurs. So what exactly happens when there is a respiratory compromise? What are the findings that we can see when do an ABG? So there will be a decrease in arterial PO2 because of type 1 respiratory failure, increased alveolar-arterial oxygen tension gradient, and there will be respiratory alkalosis, mostly because of hypercapnia. Obviously, if there is a massive pulmonary embolism, then there will be an increase in dead space resulting in acidosis. Apart from that, increased total dead space we have already discussed, increased anatomical dead space and increased physiological dead space occurs. So this is the pathophysiology. This is the pathophysiology of how the RV and LV both are affected. And this is how the CV compromise occur, cardiovascular compromise, respiratory compromise, and the findings on the ABG. So clinical presentation, among the symptoms, the dyspnea is the most common, 73%, followed by pleuritic chest pain. We classically consider hemoptysis with pulmonary embolism, but that is only occurring in around 13% of cases. So dyspnea and pleuritic chest pain are more common. And among signs, once again, respiratory signs are more common, tachypnea with rales. Tachycardia is the third most common. And circulatory collapse, obviously, if there is a massive pulmonary embolism, but that only occurs in 8% of cases. So just because the patient is not collapsing or the cardiovascular collapse is like, the NORAD requirement not that high, the patient is maintaining a lower side of MAP, obviously do not rule out pulmonary embolism based upon that. We shall see how to rule a pulmonary embolism also, because that is more important than the other features. And fourth heart sound, accentuated pulmonary component of secondary heart sound are also present. Those I believe are difficult to understand and for critical care physician rather than a cardiologist. So rely on dyspnea, pleuritic chest pain, cough, hemoptysis, tachypnea, tachycardia, and circulatory collapse. So clinical impression alone has a sensitivity of around 85% and specificity of 51% in diagnosis. So we suspect pulmonary embolism. Suspicion of pulmonary embolism is very, very important, because if it does not enter your head that the patient may have some embolism, then it will never suspect it and will never go in that part of the algorithm. So the lab test CBC is very much supportive. Leukocytosis, elevated ESL present in almost all patients of ICU. But the other three, D-dimer, BNP, and troponin, these are very important. D-dimer we shall discuss in some details later. We shall see that D-dimer is increasing in a lot of cases, including AKI, ALI, sepsis, as well as other vascular problems. Whereas there are some formulas and tricks which will make you correlates age with D-dimer, and if the age is more than 50 years, then the D-dimer into 10, then the age into 10 is the the approximate value for a normal. So for a 65 years old man, 65 into 10, around 650 to 700, that will be normal value. So anything around 700 range will not be elevated for that person. We shall discuss it in one slide later. Whereas BNP and troponin, both are markers of cardiac injury, but they are limited diagnostic value, more for ruling out the pulmonary embolism rather than ruling in. So more for negative predictive value. What are the ECG changes? Classically, it is a S1Q3T3 pattern, but it is present in less than 10% of cases. The most common is tachycardia, plain simple tachycardia, and non-specific ACT changes. As usual, as mentioned here, there is a 5-6 arrhythmia can occur, which encompasses a lot of things. But remember that tachycardia is the most common. Non-specific ACT changes can also occur, whereas S1Q3T3 pattern is quite uncommon. So in this, there is a this is the S1Q3T3 pattern is seen, but there is also an RBBB is there, and there is a RA. This is a the axis is towards the right. So this is a typical ECG pattern of pulmonary embolism, but you will not get this ECG finding in most of the patients. In most of the cases, there will be simple tachycardia. POV inversions, if present, are the most specific ECG findings, especially if POV inversion in inferior leads. So one is the most common finding present, one is the most specific findings present, and S1QC pattern is most classically associated. So three different things. Chest X-ray, MCQ favorites, Hampton's Hump sign, Ostermark signs. Present, this is the Hampton's Hump sign, also marked by the arrow. And this is the polygamia on the right-hand side in the Westermark sign. These are MCQ favorites, but highly non-specific abnormalities. If not present, then there is some negative predictive value. But with so many clinical features and ECG findings, echo findings, if there is bedside echo available, you don't need to look for these chest X-ray findings. But the names are very classically associated with pulmonary embolism: Hampton's Hump and Westermark's. So these we have discussed. It's a recommended diagnostic strategy based on clinical probability, assess either by clinical judgment or by validation prediction rule, which is a grade 1 recommendation. But this is only for patients without hemodynamic instability. That is quite obvious. In a patient with hemodynamic instability, we first do a transthoracic echocardiography. So coming to the scores, classically the two scores, Wells score and modified Wells score, along with the Geneva score. So Wells score, there are some items which can be there: previous PDVT, tachypnea, active cancer, clinical signs, alternative diagnosis. There is an original version. In the original version, these two, that is the clinical signs and alternative diagnosis, had a 3 score, Whereas simplified version, everything is score 1. And in a simplified version, there is a 2-level score where 0 to 1 is P is unlikely and 2 or more than 2 P is likely. So if any 1 is present, then it is unlikely. More than 1 present, then P is likely. Whereas a 3-level score is also there, that is a low, intermediate, and high. And the simplified version, we do not do this, which is not applicable. It is the original version with these cutoff values, it can be used. So, well, this is the OL score. So there are some items. There is the original version, there is simplified version. In the original version, we have a 3-level and a 2-level score. In a simplified version, we only have a 2-level score. This is mostly in outpatient studies, mostly to guide workup and to rule out, and not meant to diagnose PE. There is a pulmonary embolism rule out criteria, PERC criteria, PERC. As you can see, age 50 years, heart rate, that is no tachycardia, no oxygen need, no hemoptysis. So if all these are present in an ICU, you won't suspect a PE, right? No prior DVT, no unilateral leg swelling, no surgery trauma. So PERC criteria is not that useful in an ICU at all. So the revised Geneva score is the second popularly used criteria or the score to, classically that we use in a case of suspected case to rule out PE, not to diagnose PE. Once again, I am stressing. There is an original version, simplified version. There are more number of items present here than the well score, and there is also a 3-level score and a 2-level score. The classification is different. In a well score, it was 0 to 1 and 2 or more than 2. In Geneva, it is 0 to 2 and 3 or more than 3. So if 2 features are present, suppose a patient with surgery presenting with hemoptysis, so even then P will be unlikely. But in that, you have to rule out that like the chance of P in the patient is low. So clinical judgment is very much important. For example, if patient is only having an active cancer hemoptysis, chance of P is pretty much high. But in a revised Geneva score, the score will be 2. So we have already discussed about the OL score. The revised Geneva score is similar. So there are the more number of items that are there in the revised Geneva score. There is the original version and there is a simplified version. Just like the OL score, there is a 3-level score and a 2-level score. In the 3-level score, there is a low, intermediate, high, 2-level score. Unlike the OL score, where the cutoff was 0 to 1 and 2 or more than 2. In revised Geneva, it is 0 to 2 and 3 or more than 3. So in the patient, so do not try to diagnose pulmonary embolism based upon the revised Geneva score, because the patient with active cancer hemoptysis, where the chance of P is very high, there also it will give a P is unlikely.
Just a minute, Dr. Saha. Dr.
Cases where the chance of pulmonary embolism is low. So this is a patient with a hemodynamically stable patient. So in them, we have to first use the clinical features, look at the ECG, echo, and the background history, and assess whether it is a low or intermediate clinical probability. And if the P is unlikely, then go for a D-dimer test. If negative, then no treatment. If positive, then go for a CTPA. So this is the usefulness of D-dimer test. Whereas in a hemodynamically stable patient, if the patient is not high clinical probability of P, then do not use the D-dimer, directly go for the CTPA. In a D-dimer is elevated along with this in an ICU, it can be elevated in sepsis, surgery, liver disease, kidney disease, vascular disease, malignancy, pregnancy. So sepsis with liver or kidney disease involvement is the most common scenario in any medical ICU. So D-dimer will be elevated in those cases. So it has a low specificity but a high sensitivity. It has got a low positive predictive value. So mostly used to rule out pulmonary embolism. So this whole blood point of care test, its a turnaround time is 2 to 5 minutes. That is its advantage. But sensitivity is low, 83%. Whereas the ELISA or the ELFA, the sensitivity is high, especially the ELFA, which is the enzyme-linked immunofluorescence assay. The turnaround time is only 35 minutes. So that is its advantage. Now this adjusted D-dimer, as we saw, D-dimer increases with age. So if the age is over 50 years, then simply multiply the age by 10. That is for a 60 years old person, 60 into 10, 600. So that will be the cutoff value. So if the D dimer is 550, 600, or just plus minus 50, 600, 650 range, then for that individual it is normal. So do not think that it is D dimer increase for that patient. Whereas, and this is one thing. The second point is there are three components: signs of DVT, hemoptysis, and PE as the most likely diagnosis. So exclude PE if there are none of these three are present, plus D dimer is less than 1000, or if any one of them is present and D dimer is less than 500. Why do you want to do this? So that the cost of the patients decreases, so that the reduction in imaging occurs. We shall discuss in the later slides why this reduction in imaging we need, especially in these patients, because of the CTPA, exposure risk, and those things. So that is why we are trying so much to rule out PE before we go for the imagings. Otherwise, in hemodynamically stable patient directly to a CTPA, we can get the result and we can proceed as such. But they do not want to do that. Okay. So now this is a suspected PE in a patient with hemodynamic instability. Just a minute. So in a patient who has got a hemodynamic instability, so an unstable patient, the first site is bedside transthoracic echocardiography. And there we have to see for RV dysfunction. If no, then that practically excludes PE, or that not excludes PE, sorry, it excludes a hemodynamically significant PE. So basically the PE is not causing any RV dysfunction or RV strain, right? So it does not exclude the PE, but it excludes the hemodynamically significant PE. So you can search for other causes of shock. Whereas if RV dysfunction is present, then immediately you can go for a CTPA if feasible. But in many cases, because the patient is in shock, it is not feasible. So we can simply go for treatment. So TTE, RV is not working properly, start treatment. It is as simple as that. We do not need to wait for any other features. And if obviously if you can do a CTPA, if the patient is not that hemodynamically unstable, we have got the pros and the cons, and the higher chance of bleeding. You do not want to thrombolize that patient. You do not want to treat that patient immediately. Then you can go for a CTPA also. Now these are the echocardiography features. These are a bit advanced, but we shall just discuss it in 1 to 2 minutes. So what are the features that can occur? First is an enlarged right ventricle. That is number one. Second is a dilated right ventricle with the RV-LV ratio more than 1. We know that usually the LV is more than the RV. We know that the LV is more than the RV. And in this case, because the RV has increased, so RV-LV ratio has become more than 1. And third is McConnell sign. If possible, if I do not know whether you can write in the chat box or not, but you guys can write in what is a McConnell sign if somebody knows in the chat box. We shall discuss this later in the next few slides. So one is enlarged RV. This is number one, enlarged RV. This is just a confirmation of that same thing. Second is a flattened intraventricular septum. If you remember, we discussed in the pathophysiology part that the RV is putting more pressure. RV is putting the more pressure. This was the LV initially, the septum initially. Now it has become like this. Okay, so this is a new septum. So LV, is becoming very much compromised. So LV is now becoming D-shaped. So these are the findings that will need to happen. Even you do not measure the TAPC, you do not measure this S prime, not needed actually. By these features, you can get an idea that yes, the patient may be having some sort of right ventricle dysfunction. Apart from that, obviously the distended IVC, 60-60 sign present in only 12% of patients. But once again, as I told in the chest X-ray, fancy names. So you can, if possible, you can measure it. 60-60 sign. Right heart mobile thrombus, once again visible in very less number of patients. But these two are very, very nice, especially if somebody who has got basic training in echo. Then M mode, you can measure the TAPC. If the TAPC is less than 16, then there is a high chance of that is RV systolic dysfunction. And if you can do a tissue Doppler imaging, if your machine permits TDI, and if you can get the S prime, then the S prime less than 9.5 per second is also a measure of the tricuspid regurgitation and the overall right heart dysfunction. So simply measure the RV by LV, get the shape of the LV. look at the interventricular septum, TAPC, IVC. These with basic critical care, who is working in critical care, these things needs to be there. Whereas the TAPC I included is tissue Doppler and CT60 sign and McConnell sign. These are also there. These you can see. So this is just a video. Obviously, this is the orientation is like you see in an echo machine. This is left. This is left, this is right. The right is obviously very much dilated. The septum is bulging towards the septum is bulged, and the LV is more of a D-shaped. That was that. This is the underfilled LV, D-shaped LV because of less LV preload. Same thing, D sign. This is a short axis view, short parasonal short axis view, where you can see the D sign. McConnell sign. As I told you right in the chat box, I'm not checking right now. Sorry, I should check at the end. I'm worried about the connection thing. This is dilated RB, dilated RA, and the tricuspid regurgitation. As you can see, the blue line which is coming into the RA. So these are the things which you need to look in the echo. Sorry. Imaging wise, finally we have come to CTPA. CTPA sensitivity, specificity are pretty high. It is an excellent test. It is an imaging modality of choice. Sensitivity is 90%, specificity 96%. And these are the signs that you can see in a CTPA. The polo sign, thrombus is there. This is a cramp tract sign. Thrombus is extending into the subsegmental. This is segmental, subsegmental. This is in the main artery. And this is obviously a saddle thrombus, which is got into both the left and right parts. So this is the CTPA findings. Anybody who is working in ICU, I think, have looked into these findings and know how to interpret. So we looked at the chest X-ray findings, the clinical features, the D-dimer, troponins, the BNP, anti-proBNP things, and we looked at the flaws of those things: chest X-ray, ECG, echo, CTPA. And now we have come to VQ scan. VQ scan is mostly reserved for patients whose CTPA is contraindicated or inconclusive, especially in pregnancy. We shall see whether in pregnancy which is the imaging modality of choice, CTPA or VQ scan. It is CTPA. VQ scan is not the imaging modality of choice in pregnancy also. We shall discuss it in the last few slides today. So how to interpret? In a patient with a normal VQ scan, any clinical probability, you do not need a further testing. So normal VQ scan basically means there is no VQ mismatch, which is the pathophysiologic hallmark of P, right? So if this is not present, P is also not present. So that is the underlying principle of VQ scan. In a patient with low probability VQ scan and low clinical probability, no further testing is needed. But with a high probability VQ scan and high clinical, immediate treatment is needed. So either the patient do not have a pulmonary embolism or the patient has a pulmonary embolism. So low probability, low clinical probability, high probability VQ, high clinical probability. Any other combinations, further other testings are required. You cannot interpret VQ scan results.
Yeah. वो इतना टेंशन में आया था ना, अंदर तो कैसे सूख गया था ना, बाकी क्या यार करियर में ऐसा
It's a request to all the
MRI, catheter-based angiography, SPECT scan, and lower extremity USG Doppler, which also needs to be done. Obviously, lower extremity USG Doppler is the finding to rule out DVT. That is one of the initial tests that we do. MRA, catheter-based pulmonary angiography, these are gold standard. Catheter-based angiography is a gold standard, but almost never done now, only of historical significance. So why are we so much worried about CTPA? Because the radiation effective dose is 3 to 10. Significant exposure to young female breast tissue. Whereas in a VQ scan, the radiation is lower. This is the main advantage of whether it is a VQ scan or a VQ SPECT scan. The lower radiation is the most important thing. Pulmonary angiography is gold standard. It is a highest radiation dose. It is not done. So no need to bother about that. So main problem with CTPA is the radiation. This we already discussed, the clinicals, imagings, and the lab biomarkers. And This is the odds ratio of getting a positive finding in an echocardiography, CT angiography, BNP, NT-proBNP, etc. So as we can see in the remarks part, I'm just enlarging it. RV dysfunction echocardiography was one of the inclusion criteria to RCTs investigating thrombolysis. So you can understand the importance of an RV dysfunction echocardiography. So that was one of the inclusion criteria in the multi-center, multinational RCTs on pulmonary embolism. This is the prognostic role echocardiography. Prognostic role is there if there is a no RV dysfunction or moderate RV dysfunction based upon the TAPSI findings. The more the RV dysfunction is there, more dysfunction will be there also. That is the worst finding because the more chances of hemodynamically significant embolisms. This is the PACI score, pulmonary embolism, pulmonary severity index. There are number of parameters are there. There is the original version, simplified version, just like the Wells and the Geneva's criteria. Based upon the points, they have certified as class 1, class 2, class 3, and class 4, and also class 5. Class 5 has got a very high mortality of up to 25%, and class 1 obviously has got a lower mortality. So this is first mortality certification. PACI is for mortality certification. Okay, PACI is for mortality. Wells and Geneva also ruling out PACI is for mortality. Based upon this, high, intermediate, low, intermediate also explained as intermediate, high, intermediate, low. High, if the patient is hemodynamically unstable, the indication of risk will be high. So early mortality chance is more. Otherwise, it can be intermediate or it can be low mortality risk. If intermediate high, that means patient is hemodynamically stable, but clinical parameters are positive, RV dysfunction is there, and elevated cardiac troponin levels are also there. So echo and crop. Intermediate high, intermediate low, if patient is hemodynamically stable, clinical parameters are there, and any one of echo or troponin levels are positive. And low obviously means these things are not there, but we are just clinically suspecting it. Other prognosis scores are also there, just for completion's sake I added. I don't think I need to go into details about that. So now how to treat these patients? Treatment for a high-risk pulmonary embolism with a hemodynamic instability. Point number 1 is give heparin, 80 international units per kg IV, and then maintain with 18 international units per kg per hour. ECG to exclude ACS, not to diagnose pulmonary embolism, but to look for ACS. As we discussed, ECG is highly inconclusive and tachycardia is the most common finding. Echocardiography obviously to do, we have discussed in details. And after initial stabilization, if possible, then go for a CTPA. If the patient is still unstable, consider early ECMO. This has come into the recent guidelines. I have included a couple of slides later on ECMO and PE. Consider early ECMO if the patient is hemodynamically unstable. And then we have already started heparin, and then go for a deperfusion therapy. Whereas in intermediate or low risk PE, obviously anticoagulate first. So anticoagulation and heparin will be there in both, in any case of pulmonary embolism. Go for heparin. If hemodynamically unstable, then deperfusion therapy directly, because immediately the patient becomes high risk. So maybe initially the patient was hemodynamically stable, and then you give heparin, and then the patient became hemodynamically unstable. So immediately go to this, that is this high risk PE. So that is a separate entity. So that is separate. Now suppose the patient remained stable. So patient is still stable. So use the clinical signs, use the echo, use the troponin to subdivide it as intermediate low risk or intermediate high risk PE. Depending upon that, treatment will be there. If intermediate high risk, then monitoring. Intermediate low risk, definitely hospitalized, may not be in a monitored bed. This is mostly theoretical. Nobody with a diagnosed PE will keep the patient in the general ward. And if the patient has got none, so it is low risk, then comes the suspicion of early discharge of home-based treatment or other therapies. But that needs to be done only after ruling out all the differential diagnosis of PE. including ACS, most importantly, along with pneumonia and malignancy and underlying cancers, those type of things. So we have discussed about heparin, the dose, and now we have come to the concept of anticoagulation. So basically there are 3 phases: first 10 days, long term, indefinite. We shall discuss the acute phase because that is what we shall deal with in an ICU. Before discussion, we shall go look at, we shall discuss about that first only. Yeah. So we have got a lot of choices of anticoagulation: low molecular heparin, unfractionated heparin, fondaparinux. So we have to first see whether the patient is suffering from malignancy or the patient is overweight, patient has got a CKD, patient has got a previous bleeding history, and what is the bleeding risk now. Depending upon that, we need to decide. Number of scores are there. Hasbled is the more commonly used score. Uncontrolled hypertension, liver renal dysfunction, age, bleeding history, previous stroke. 3 or more than 3 is high. This does not mean whether we shall, start the reperfusion therapy or not. Reperfusion to be given regardless. This is only to prognosticate the patient or the patient relative about the high bleeding risk, so that we can be more careful. Do not think that if the bleeding risk is high, we do not need to reperfuse this patient who has got a pulmonary embolism. This is same in case of AF also. So that is the point there. So select. Okay. Background noise. Unfractionated heparin, where you use low molecular heparin is the usually used. Unfractionated heparin in hemodynamically unstable because in low molecular, because we have got a reversal agent. If the create clearance is less than 30, severe obesity, and APDT needs to be done 6 hourly. This is the usual chart for unfractionated heparin for titration of dose. You can see that target APDT is 46 to 70 seconds. Depending upon how much APDT you are getting, you can change the dose. And what are the other options? Fondaparinux is another option, and another option is NOAC. So whenever oral anticoagulation is started in a patient is eligible for a NOAC, and NOAC is recommended preference for VK. VK is warfarin. Warfarin is no longer commonly used in the case of pulmonary embolism. It is UFH, LMWH, fondaparinux, and NOACs. Okay. These are the doses I think we know. Fonda is 5, 7.5, 10. One of the final question in my DM final exam was this. Dose of chance of heparin is much less, but Fonda so we're waiting for for this 24 hours to pass. Anyway. And these are the NOACs. Apixaban is the more commonly used in the corporate setup or in any setup. It is 10 milligram BT for first 7 days, then the usual 5 milligram BT dose for elixir or apixaban. Target INR is 2 to 3 if you are using warfarin. So we have discussed about heparin, low molecular heparin, these things, and now we are coming to this reperfusion. So what are the agents? Agents, streptokinase, urokinase of historical significance or used in the peripheral setups. In our setups, RTPA, the altiplase 100 milligram IV over 2 hours, and this is the dose in a young patient or a low body weight patient, 0.3 milligram per kg IV over 15 minutes, maximum dose of 50 milligram, which is the low altiplase. We shall discuss the trials dealing with the low dose of altiplase and whether you should use or not. So contraindications are mostly hemorrhagic stroke, ischemic stroke in 6 months, bleeding problems, actively bleeding, major trauma in previous 3 weeks, and whether we should anticoagulate and formalize together. The simple answer is no. USA guidelines
clearly states discontinue anticoagulation therapy before and during thrombolytic infusion. And ESC, European guidelines say UFH may be administered, but I have discussed this with people who have come to practically used. MOPED trial, one thing was whether thrombolysis should be used in moderate thrombolysis also. So, where's the conclusion? Low dose thrombolysis is safe in moderate P. But what is moderate P? We have not discussed anything called moderate P till now, right? Moderate P is not a term. These patients' inclusion criteria was this: hemodynamically stable, moderate P. So the main problems was with this study was small sample size, low prevalence of RB dysfunction, RB hypokinesis. So patients' immune probability thrombolysis was not needed at all. So this study did not prove the systemic thrombolysis prevents the ultimate development of pulmonary hypertension. And currently, in a case of hemodynamically stable pulmonary embolism, thrombolysis is usually not used. That's the reason, because of the higher chance of bleeding, especially in a case of if you do not need it and the patient bleeds in the brain. We recently had a patient who had a CVA, but the patient expired in the next 2 days. So you cannot do anything if the patient develops a massive hemorrhage in the brain. What about low dose systemic alteplase? Once again, routine use is not recommended. That 50 milligram thing is not recommended at all. So do not use it. With intermediate pulmonary embolism, once again, hemorrhagic stroke, extracranial bleeding, everything is higher. So, and mortality, no significant difference. So once again, do not use it. So these are the usual clinical, day-to-day life. Whether you should visualize the patient intermediate risk or moderate mortality, P recurrence rates were low. Major hemorrhage and fatal intracranial hemorrhage was significantly more frequent. But in a case of for acute pulmonary embolism, where the patient is hemodynamically unstable, they have got a definite mortality benefit. So taking into account the chance of the major hemorrhage, we can use it. We should use it. Coming to the patients where we cannot thrombolyze, there are the options of surgical embolectomy, catheter-directed treatment, and IVC filter. Surgical embolectomy resulted in fewer recurrence, fewer deaths, but not statistically significant. So only numbers decrease, not the statistically significant. Catheter-directed treatment, it is used in cases where the patient cannot be thrombolyzed because of higher risk of bleeding. Femoral route is used. Success rate is 81%. Major complication rate is around 6.7%. There is a high clinical success rate, but and more effective if ultrasound assistance is there. And IVC filters, once again, should be used with acute P and absolute contraindications are there. It is a 2C recommendation. Should be considered in case of recurrent P, but a routine use is obviously not recommended. And this is just to show the filter is located at the correct position. No mortality benefit, decrease recurrent, increase recurrent DVT. So P decreased, but DVT increased. Now, for surgical patient, there is a separate score called the Caprini scores for the assess the VTE risk. So these are the points that they use. Among the maximum 0.5 points each: stroke, elective arthroplasty, fractures, lower limb fractures, and acute spinal cord injury less than 1 month. Depending upon that, there is surgical risk category of low, moderate, high. You can see there is some scores and estimated VTE risk. So you can counsel the patient and the relatives based upon that, and you can start treatment prophylactically if you want. So this is a Caprini score. There is also the Rogers score, which has got a similar benefit, just the general risk factors are a bit different. Yeah. So this was the sort of the surgery is with THR or TKR or a hip fracture. Okay. So THR TKR duration of anticoagulation is usually 10 to 14 days. Only for the surgical parts. Other indications it will be different. Hip fracture similar. Surgery is likely to be delayed you can start low molecular heparin after 12 hours prior to surgery or 12 hours after surgery. So there are different guidelines. I won't go into details, but these codes are there, these guidelines are there. This is because orthopedic cases are notoriously known to throw pulmonary embolism. So that's why separate guidelines are there. I just wanted to know that there are guidelines. So in a hemodynamically unstable patient, along with this heparin and the antiplase, you also start the vasopressin, right? So what is the goal? The goal is to keep the systemic vascular resistance much more than the pulmonary vascular resistance. And among the common vasopressors we use, the norepinephrine, epinephrine. Here the PVR by SVR ratio is showing. Both of them increases the SVR PVR both, but both of them increases the SVR more than the PVR. So PVR SVR ratio is negative. So you can use either epinephrine or non-epinephrine. Do not use dobutamine or milrinone in these patients because there our goal is not matched. Don't think anybody is using milrinone in a patient with pulmonary embolism. So that is that is the science behind that is the scientific principle behind why if you use epinephrine or non-epinephrine or even vasopressin for that matter. So the three most commonly used inotrops, those are also to be used in pulmonary embolism. No issues there. Even if you don't know and you directly use anything, you can be safe. Vasodilators, is there any role at all? We just told that vasodilators will be bad. There are trials, inhaled nitric oxide as a salvage therapy. The outcomes are not that good. Inhaled nitric oxide failed to increase the proportion of patients with normal troponin echocardiogram, so not to be used. Finally, coming to the last part of the presentations, ECMO and pregnancy. ECMO is an upcoming thing. ECMO saves lives. Early ECMO in a good center, obviously a well-qualified doctor and the perfusionist. ECMO saves lives. High-risk pulmonary embolism. If the other things are not working, think about ECMO and transfer to an ECMO setup if possible. This is a similar thing, but overall survival was increased. But obviously, this is a new upcoming thing, and then recent guidelines, ESC guidelines, they have added a separate small paragraph on ECMO. So they are also considering. Obviously, they are considering. That's why we are putting it in the PPTs. It's an upcoming thing, and it's a very interesting thing because pulmonary embolism is a preventable thing. If not preventable, with the antiplase and the heparin, it's a treatable thing. If we can regularly use ECMO in this, then it will be, the death rate discussed in the first slide. It has come down to from 6 per 10 per lakh to 4 per lakh. So it can come down even more. These are not going. Finally, going to pee in pregnancy. The thing with pregnancy is that D-dimer, which is already less value in diagnosing P in ICU, in a pregnancy, there is even lesser value because a 25% rise is physiological. So you cannot use the D-dimer in pregnancy. So what you can use? We can use CTPA. So the good old CTPA we can use. No need to go for other diagnostic tests. Why? Because CTPA, modern CTPA, has got negligible lifetime risk of cancer. So avoiding CTPA on the grounds of maternal cancer risk is therefore not justified. Very, very important, not justified. Do a CTPA even if there is pregnancy. Pregnancy is not a contraindication for CTPA. Yes, you have to explain the risk to the patient or the relatives and they can inform consent, obviously. But that you have to take it for a central then also. So these are the fetal radiation exposure and the breast radiation exposure. As you can see, chest X-ray is this thing. And in a case of CTPA, it is 0.22 to 0.66 and 10 to 70. So exposure to maternal breast tissue is more. Obviously, it is more. But in a case of pulmonary embolism in pregnancy, it's life-threatening. So CTPA is the imaging modality of choice. And what is the treatment? Treatment, low molecular heparin remains the treatment of choice. Warfarin is a contraindication in pregnancy, especially in the first and the third trimester. No warfarin. Even in non-pregnant, not using warfarin, and no NOACs because of lack of trials. Okay, so no NOACs, no warfarin. Thrombolytic therapy in life-threatening cases you can use, but otherwise should not be used because the chance of fetal demise is almost more than 70% in case of if you use thrombolytic therapy. But life-threatening, always the maternal life is better, you have to save the maternal life. That is the priority. So you can use in that case. So CTPA, low molecular heparin, thrombolysis can be given. So nothing much different from our day-to-day practice. Only thing is that no NOACs. Breastfeeding also same thing, no NOACs. So suspected PE during pregnancy, anticoagulant LMWH, do a chest X-ray, do a DBT scan, and specific investigations for PE. If chest X-ray is normal, you can go for a CTPA. If chest X-ray is abnormal, you can also go for a CTPA. So CTPA in both. But if chest X-ray is normal, you can go do a DQ scan also, perfusion lung scan also. If P is ruled out, well and good. If P is not ruled out, you can continue low molecular heparin. If hemodynamically unstable, you can thrombolize the patient. Okay, so these are the case studies that we have included. Low risk P, triage for early discharge and home treatment, but only after ruling out all other causes of all of the other differential diagnosis and making sure the patient actually not suffering from a condition. You don't want the patient to go home and then suffer a P. The patient will die and you will be in a lot of trouble. Okay, so these are the changes and recommendations. I think we have discussed this in the slides only. So no, I won't be going through these again. And these are the sources, and I'm grateful to the ESA guidance up to dates. And I have taken a lot of slides from my AIMS colleagues of All India Institute of Medical Science, New Delhi. I'm really grateful to them for allowing me to use their slides here. Thank you. I think I can take a couple of questions. I'm still working in the ICU, and there are 2 new patients who have come. So I can take a few questions and then I need to leave. Sorry for that. But yeah, it was a pleasure.
Yeah, that's Dr. Asif. Thank you so much. I think very elaborate and you've covered everything quite in detail. So that was good presentation overall. So quickly, if you can take one question which has already been typed in there and put up, like in a patient of ARDS, and this patient has pulmonary embolism. The patient is already in a vasopressor. So what would be your plan B?
So sir, first you have to see that the patient is having a pulmonary embolism and whether it is like adding to the hemodynamic instability or whether hemodynamic instability is present for the first thing or not. So if the patient is if it becomes hemodynamically unstable because of this pulmonary embolism and there's the RP strain as we discussed, then we can use and we can assess the bleeding risk and we can go for the usual management of pulmonary embolism, heparinize and go for alteplase. If you think that the hemodynamic instability only because of pulmonary embolism, not because of the hypoxia or because of the sepsis or septic shock. Okay, so I don't see any more questions. So we have already up with the time that was allotted. And thank you once again, I think, for very elaborate discussion and taking us through about each and every factor of pulmonary embolism. So Ms. Sana, if everything is done, no more questions, can we close it, the session?
Okay. I don't think we have any more question. Well, I want to thank you, Dr. Asif Ahmed and Dr. Sangshaptak Saha, sir. Thank you for being in this session. And it was very enlightful, very interactive, and very informative. Thank you.
Thank you all. Bye-bye.